Good. Well, welcome everyone. It's always a pleasure to see lots of new faces whenever we come to these meetings. You think diabetes is a field that's a bit static, but it's not. There are lots of new people coming in and lots of old people like me who need to be leaving. So I'm not on a soapbox trying to find a successor, but please come and talk to me if you're interested in taking this job over. It's always a pleasure to stand here. I'm the spokesman. The team at the RCPCH are the people who do all the work, led by the lovely Holly, and I just get to see all the lovely crushed data and the graphs and come to talk to you at meetings like this, which is always a pleasure. So I start with a bit of a spoiler alert. I'm not going to tell you who wins Traitors tonight, but I've got to get home for 9 o'clock tonight. The spoiler alert is that this is 2022-23 data. It is as yet not in the public domain. You cannot take photographs of this. I have special permission to show you it by HQIP, our commissioners, through NHS England and NHS in Wales, but you can't take it away. You've had your PDU level reports. They should have come through to you in the last few days. So you've got a lot of that information in there. But again, you're only allowed to circulate that within your own unit at the moment. The other thing that I noticed when I was just checking through these slides this morning is this picture here, which I've used for years, is a little bit outdated, isn't it? It's what diabetes used to be like, a little girl there taking a finger prick blood glucose level, and I should think in the next 5 to 10 years, probably people won't be doing that at all anymore, and it's gradually already changing. So I'm going to have to change my photograph, I think, if I stay here much longer. So I always like to start with this gentleman, and you've seen this in my talks before. This is Lord Deming, Edward Deming, who is the forefather, if you like, of audit. And I mean audit in a wide bridge, because he wasn't in the NHS, he wasn't in health. He was an industrialist, he was an economist, he was a brilliant statistician. And his interest was in quality improvement, improving systems. He did a lot of work with the Ford car industry, improving the output through their factories. And he gave his name to the PDSA cycle. A lot of you will call it the PDSA cycle, but in fact, I quite like to call it the Deming cycle, which a lot of people still use. And it's this simplistic plan, do, study, and act. And you can go round around this circle, improving qualities. You start with the NPDA, we start with the planning phase, which is to have some standards. And if you haven't got standards, you can't start your audit. So we have standards. We have NICE standards. We have ISPAD standards. We have all sorts of standards we can go to measure ourselves against. And then we can go out and collect the data. And that's where you come in, because you have to collect it and send it to us. And then it comes back to the college. We analyse it all, produce nice graphs, have many discussions on how the output should look. And then it comes back to you, and hopefully you act upon it and make some changes that you think will improve your service. And then you go round again, and you can do little cycles within cycles and multiple cycles within cycles, improving. And you'll all be very familiar with this process. So I just show you that to make sure we're all on the same plane when we think about audit. So I start with what's the prevalence of diabetes in 2022-23. So it's always difficult because we don't know what the denominator is, because there are, at the age of 16, 17, there are still people in paediatric centres, but there are also some in adult centres. So we don't know the true prevalence. So when I talk about prevalence, I'm talking about the number of people who are being cared for by you lot, by paediatric diabetes centres. And if you look at the bottom left hand here, we're about 34,500 people that are being cared for in about 165 centres across England and Wales. Most have got type 1 diabetes, 94%. About 3.6% have got type 2. That number's increasing every year and out to 1,200. When I first started this, it was about 200. So it's increasing all the time. And then we have a few of these rarer, MODY type forms of diabetes. So what's happening with that number? Well, I'll show you, this is the prevalence graph. So the Blue bars are England, the green bars are England and Wales combined, and the red line is Wales, which uses this axis on this side, and England and Wales this axis, this line. And you can see there's been a steady increase in that prevalence over the last 7-8 years I've shown you there, from about 27,000 up to now around about 35,000. So in 7 years, it's gone up by 7,000 children. There's 7,000 more children being cared for in a paediatric centre. 7,000 children is roughly about, for an average size DGH unit, is about 40 more children that you're caring for now than you were 7 years ago. If you multiply that up by at least 4 clinic visits a year, each of half an hour, all the telephone calls, all the putting on pumps, all the putting on CGM, it's a lot of work. It's easily enough work for one extra PDSN, probably another consultant, and all the other people, dietitians, etc., that go with it. So there is clearly data that that we need more people to run the service, or we need to think in other ways to run the service. So why are we increasing? Are we getting more into the system, or are less leaving the system because we're just a holding bay for transition? So I showed you last year how there was quite a massive increase in the incidence of type 1 diabetes following COVID, and this has been shown across many international studies and registries now. Nobody really knows why there's been a sudden increase following COVID. Maybe it's some sort of immunogenic process. But here in 2020-21, you saw this massive jump, having been pretty stable for some years prior to that. And last year it stayed up, and this year it's come down a little bit, but it's still much higher than it was back here. So there are more people coming into the system, and some of these are quite young, of course. So I asked Sarah, our statistician, to look at transition, because I had a feeling we were hanging on to them a bit longer because adult services were in more disarray than we were post-COVID. But in fact, it's not the case. It's pretty much stayed pretty stable. The number going out of the system has stayed the same. So the reason we're going up is there are just more of them. So let's start with the care processes, health checks, whatever you want to call them. These are the 6 which we now cover. As you know, we've taken retinopathy out of the essential care process because now it's moved to a biannual requirement, and that makes it more tricky to analyse. We still will present outcomes from that retinopathy data, but it's more difficult to include it as an essential care process, which is a pity. I think it's a great pity, and many of us do, and some of us are still fighting that a little bit. So watch this space. So, so each of the lines represents one of the care processes, care checks. You can see lovely improvement. COVID, that big dip was COVID. We couldn't see our patients apart from on video screens or coming through drive-throughs and things like that. But look what's happened post. It's recovered pretty much to where we were prior to COVID. So that's fantastic news, and that's really, it's got you to thank yourselves for that, because we got back on top of all those measurements again. So those are individual checks. And I'm now going to introduce you to a new plot. You won't have seen this one before. This is a new thing. It's called a violin plot. I thought it was great when I heard about it. And it's called a violin plot because it looks like a violin, doesn't it? Upside down violin. So this is a plot. I'll lead you through. This is a plot of the health check completion rates for an individual centre. So it takes if you have 100 patients in your centre, and they've each got to do 6 checks on each of them, you should have 600 checks if you're 100%. If you have 300, you get 50%. If you have 450, you're going to get 75%. So that's how it works. And this year we've included, we used to just do children over 12. As you know, children under 12 have to complete 3 checks, an HbA1c, a height and weight, and a thyroid function test. Yeah, thank you, Fiona. We've included them as well. So if they score 3, they get 100% for you. So that's a bit of low-hanging fruit. And what this, so each of these dots is a centre. The average is just over 90% completion. Big bulge here because most people are around about that 95, so it's not normally distributed, this data. But there are still one or two centres down here. And we have permission now from CQC to change the way we provide an outlier for this completion rate using this technique. It will produce slightly less outliers than we did previously, which I think is not a bad thing, but it'll still catch these ones right down the bottom here who will have to answer for why they're a bit lower than the rest. So the violin plot is here to stay, hopefully, as long as it gets through the process of approval, which is going through at the moment. So this is the slide everyone likes to see each year. This is the median HbA1c for children and people with type 1 diabetes, going back to 2010-11, and that's when I started doing the audit with the Royal College. And we choose to use median rather than mean, partly because it gets you a slightly better result. It's about 2 millimoles lower than your mean, but the data is not normally distributed, so statistically it would be better you use a mean. And then every child that has more than one HbA1c done in a year, we take the median of those 4 values. Hopefully there are 4 of them. They're sometimes more, sometimes less. And so this is crush data for England and Wales. And you can see there's a steady year-on-year improvement, but I've just broken it up to make you think a little bit about this data. So this is the first half, the first 6 years, with showing a trajectory which is about 1 millimole less per year, which I think is about as much as you could achieve really in any system. You might get up to 1.5, 2, but there were some good years in that and some not quite so good years, but on average, we were dropping by 1 millimole per mole. And there were lots of things happening around those times. There was the formation of networks, there was the sharing of information, sharing of guidelines, peer review was starting to be thought about, best practice tariffs started to come in, lots of things happening which were strategically driving that change, but the change was being made by you lot that were out there doing the work and thinking differently about the way you managed your services. And you could say that was the low-hanging fruit, if you like, because you could go out and make a small change and make a big difference to your children. And that's probably correct, because if you look what's happened over the next 6 years, it's not quite as good as it was. It's still dropping. So don't take me wrong and say we're going in the wrong direction. We're still going in the right direction, but it's not going quite as fast. If it had gone as fast, we'd probably be down to a median of about 57 now. And we're not. We're around about 60, 61. So the dotted line is the trajectory we're on at the moment. The black line below it is the one where ideally we should have been. And again, lots of things have happened in this time as well. We've had more peer review. We've had the development of the transformation programme in England. We've had approval of CGM coming in 2018. We've now just got approval of closed loops, but it's probably too early to show that on this slide because we're not into that time period as yet. So let's hope that that dotted line is going to change and go back down to the darker line. So why is it that we're not, I wish I had the answer, why is it, say this is what you do, you go and do that and it'll improve. There are lots of reasons. One is variability. So this is the mean adjusted H1C, so we've gone to means now. We adjust your case mix, so if you have a whole load of very young, older children in your clinic, a lot of ethnic minority groups, a lot of deprived children, we adjust your data to try and make your case mix equal to each other. And that's what the adjustment does statistically. And then we plot your adjusted level against the number of people in your clinic. And if data behaves correctly, you should be able to put this funnel shape on top of it, sideways funnel, and the data should funnel. So the bigger your unit, the more you regress towards the mean. It's easier to get towards the mean than if you have a small unit. And you see that doesn't really happen, does it? It's a bit all over the place. There are loads of centres up here who are not performing so well, and there are centres, of course, down here who are performing extremely well. And I don't mean this in a negative way, but we probably need to learn from each other, don't we? And that's what we're always trying to do. If you happen to be one of these people in this centre, I bet you up the road there's one like this. Go and visit them and ask them how they do it, because you can learn it. Those of you who went out on peer review, did peer review, I learned much more doing that than I think the peer review unit learned from me. It's a great process of learning things. So the darker pink are what now forms the alarms. These are over 3 standard deviations above the mean. The lighter pink is an alert level. It's above 2 standard deviations from the mean. And there's a slight change in the outlier notification process, in that these alerts now need to be notified to CQC. Whether they'll do something about them is up to them, but they want to know who fits into that category. We have to for these 3 standard deviations, we have to go through the usual process, and some of you might have been involved in that in the past. We have to inform you and your chief executive and medical director. And these are the guys who are doing really well. I think there's a lot to learn from them. The other issue is there's still a lot of variation by deprivation, and as you know, we take the deprivation index to take your postcode of the child, and it can get converted through the index of multiple deprivation to a score, a lower super output area score. So you can divide the nation up into quintiles of deprivation, from the most to the least deprived. And you can see from this graph, so here are the most deprived up the top here, the dark red line, the least deprived down the bottom here. The good thing is that all centiles are improving. We're not gradually getting wider and wider apart, which we thought we might be back here. It's come back together a little bit. But there still is quite a difference between the most and least deprived areas, about 6 to 7 millimoles per mole. That's quite a big gap, putting your risk of future complications much higher. So that's still there, it hasn't gone away. How do we compare to other countries? And I hope I won't be treading on Reinhardt's toes. He's going to be following us. He's going to be streamed in live from Ulm, who's one of our big international collaborators. I'm just going to show you where we sit amongst the Scandinavian countries. It's all right, Reinhardt, I'm not going to talk about Germany. I might do briefly in a minute. But these are the trajectories of the 5 Scandinavian countries in terms of HbA1c over the last 10 years. And in a way, they show a similar downward trend as we have done in ours. But look at the scale here, you're down at 50. So if you live in Sweden, 51 is your average HbA1c now. I mean, that's amazing. And even all these others are doing extremely well. And if you plot us on there, it's not quite so good, is it? We're heading downwards, but we used to be sort of in the pack at the beginning here, and we've continued to come down, but some of those pack have accelerated and gone well past us. So we've got a little bit more work to do to get there. I think they're very useful, these international comparisons, and Reinhardt will talk more about it. A few years ago, we partook in an international study with Reinhardt's group. It was a chap called Demetrios Sharampopoulos, I hope I've pronounced that correctly, who went out to Ulm, which is where Reinhardt is based, and with his statistician, they got together data from 65,000 children across the countries as shown in this diagram here, and analysed the HbA1c by country, and produce this lovely graph, which I always love showing. I expect Reinhardt might show it as well, showing the HbA1c distribution by country. And I'll lead you through each country, because otherwise it's difficult to understand just these series of humps. So this red one here is Sweden. So they have a very good average HbA1c. This is the average, will be the peak here. But the other thing about them is the spread around that average is very small. So they're very tightly compacted within that. So there's no extreme outliers that are doing, or there will be one or two, but there aren't any major extreme outliers or major ones doing extremely better than their average. They're all sitting round about that level. If you look at Germany, so I said I wouldn't talk about Germany, but I'm going to just say something. So again, if you look at their mean, it's not that dissimilar to Sweden, but their spread is a lot more than that. They're much more spread out than the Swedish are. And if you look at us, this is England, Wales, we're very similar to the United States. Over here, we have a relatively poorer average, but our spread is not quite as much as the German one is, but it's not as good as the Swedish one. So we're sort of in the middle there. And then and then just slightly better than us are Norway and Denmark. Good average, moderate to low centre spread. So how can we monitor where we're heading in our country? So this is taken from the report a couple of years ago, but it still stands now, I should think, is that these are successive cohorts 5 years apart. So the yellow is 2009-10, the red is 2014-15, and the blue is 2019-20. And I think you can see there is a slow drift towards the left, which is what you wanted going back onto that international study. You want it to go to the left, and you want it to get tighter. So two things that should be happening. So it is moving to the left. You can see that, the three curves, and is getting tighter, and you can actually demonstrate that statistically by the standard deviation, which is getting less. It means it's getting more compact. So move to the left, compact your bars, and then we'll be there. It is happening. It'd be nice. We'd all like it to go faster, but it is happening slowly. So I'm not changing tack exactly, but I'm going to just briefly talk about micro and macrovascular complications of type 1 diabetes. And we don't really talk about this very much in paediatric circles because we don't see it very much. It tends to be up the road in mid-20s, mid-30s, something like that. But there are markers that we collect and we measure and we can look at. And ultimately, this is what we're trying to improve, is longevity and reduce morbidity of life. So here's the graph. So I'm going to do each of these. It won't take me very long, but do each of these. So let's start with blood pressure. So two things we've improved: blood pressure measurements, not doing the measurement, the actual value. Blood pressure above the 98th centile, that's systolic or diastolic or both. Well, the answer is it's pretty much the same as it was 5 or 6 years ago. So nothing has changed much. We look at obesity, a BMI above the 85th centile. Some hint it might actually be increasing a little bit. So are we exchanging better control for a slightly weightier population that might have other complications associated with that up the road? Don't know as yet. Cholesterol greater than 5. Again, it hasn't really changed very much. Retinopathy rates, there's a hint it might have come down a little bit, but it's still quite high. And the microalbuminuria rate is pretty similar. So we haven't touched these as yet. I think maybe we need to focus a little bit more on these. And I've been talking with Sarah, our statistician, about how we might be able to tease out some information from this to try and find out who it is that's not doing quite so well. Is it related to HbA1c? Are these things related to one another? Because I suspect they are. But it requires quite a complex statistical model. But watch this space because we're going to see whether we can do something for the extended analysis. So technology, I'm just going to move to technology. I'm all right for time, aren't I? Yeah. Technology. Technology usage in 2022, 23, and then I'm going to show you the outcomes of the usage of that data. So here we are, 45% are now on an insulin pump of some form. About 1 in 7 children are now using closed loop. Remember, this was last year, so it's probably moved on quite a bit since then, especially with the new guidance coming out. The good thing here is look how many children are on some form of indwelling blood glucose monitoring, either via real-time CGM with flash or modified flash group monitoring, it's approaching 85–90%, which I think is a really good thing, and that's why I need to change my picture at the beginning of this talk. What about the outcomes? So each of these groups represents a modality of, the pairs represents a modality of treatment regimen, and in each pair, one on the left, the bar on the left is 2021-22, and the bar on the right is 22-23. So as you move from injections alone to injections plus flash, plus CGM, onto pumps with flash, or pumps with CGM, and onto closed loop, there's a gradual and steady decline in the HbA1c, which is what we hope we might see, especially with closed loop technology coming on board here. When I first looked at this graph, I thought, oh dear, that's gone up a little bit. And I can see Fulia saying, oh, but it hasn't. But yeah, Holly's a great thinker around these things. So when I was saying, oh, but it's gone up, she said, yeah, but look at this column over there. In this year, you took the low-hanging fruit and put them on. All these are all the people who were desperate to get onto hybrid closed loop. So they were going to do well, and they did do extremely well. And now you're getting people who perhaps were less motivated at the beginning, but now are interested in doing it. So you're taking the slightly better ones out of here and moving them into here. So I think it's going to take at least another year, if not 2 years, before we see this hopefully just continuing to zip down as people disappear out of these groups, and eventually, like pre-mixed insulin, we won't be showing you that data anymore. I've just chosen to show you the CGM data that you can look at pumps and as well in the main report when it comes out. But this is the effects of ethnicity and deprivation on the right on the use of real-time CGM. So each of these blocks represents a category: mixed, white, other, Asian, black, or most to the least. I apologise for these; they weren't moving, but I think you can see what I mean. And then each column within that is a successive year. And you can see this dark blue, how there's been a massive increase compared to what there was before. Still showing changes between the most and least deprived and in the different ethnic groups. But the good thing is they are shifting. And I think everyone now is getting the message they need to perhaps focus on ethnic minorities, on people living in deprived areas. Some people say to me, but I don't know whether my child's living in a deprived area or not. You probably know your areas better than I would. We're hoping when we move to quarterly and eventually monthly reporting that we might be able to give you that information straight back. So if you put the postcode in, it'll tell you what quintile that child sits in, which might be helpful for your planning. So I finished on time, Fiona. You'd be glad to hear. So I've just pulled that. Yeah, I think so. I had you in my ear, Holly. So there have been fantastic improvements in the clinical outcomes. You can get that from this data over the last 10 years. We're approaching some in other leading countries, but we need to do a little bit better. We can get close to them, but if they can do it, we ought to be able to do it. There are these increasing numbers which we're all going to have to deal with. We don't know why COVID-19 caused these increased numbers. Perhaps more research will tell us eventually. The progressive use of technology and more advanced technology certainly seems to be associated with better diabetes control, but the inequalities are still there. We need to think about how we tackle them. We've got some speakers this afternoon talking about inequalities. And so as I said at the beginning, I'm the lucky person who gets to stand here, or maybe not so lucky if you bombard me with difficult questions. But the people who do the work are here. These are the team at the RCPTH who work tirelessly to keep you all on track and keep me on track. I thank our commissioners who are HQIC, who are always very helpful at guiding us and steering us. The people who give up their time to the project board and the data set and methodology group who keep the whole audit on track. and to you who collect all this data and send it to us. If you didn't, we wouldn't be able to produce this sort of outcomes. And finally, the children, young people, and their families living with diabetes, because these are the people we're all in this room working for to improve their quality and quantity of life. Thank you.
Amazing presentation, amazing timekeeping, and that makes my job so much easier, Justin, so that's fantastic. So we all look forward to hearing and seeing a snapshot, because there's so much more detail in the report. My message to everybody is that use the data, because when you're out and about and you're having to negotiate for extra funding, for example, to do the job we know we have to do, people want evidence, they want the data, and that's the beauty of having a fabulous audit, 100% across the country, and individual reports that you can take and say, that's the national picture, this is the local picture. We can't argue with the data, and it gives you a sound platform for negotiating. So I think that's the most important operational message, using the data. However, you don't want to hear me. So can I open to the floor? We've got a few minutes, Justin, if you don't mind. And I wondered if we could spend 5 minutes, and I'll keep to time, finish at 1:45, with any questions to Justin in his clinical lead role doing the audit. And I'll stand aside over here.
What I forgot to say before you think of any questions is when I was talking about Deming and the cycle, is that up till now this has been an annual cycle, as you know, and everyone says, well, that's fine, but it's a year out of date. It might be a year out of date, but it still tells you a lot of information. But as you all know, we're now moving in April to quarterly reporting, and in April next year, all being well, we're probably reporting monthly. That's very dependent on you putting the data in. If you don't put it in, you get no report. Well, it won't be me who comes chasing you, it'll be CQC and transformation programs. So it's up to you to put the data in there. There will, of course, be big caveats around that data, because a healthcare check is an annual process, and you might choose to do all that in March at the end of your year. And so therefore you'll get 0 through all the year. Everyone will think, what's going on with the centre? They're not doing anything, but they might do it all at the end, or you might do it all at the beginning. If you do it throughout the year, you'll gradually see your accumulation building up each time you put the data in, but it will be up to you to put the data in. The other caveat around it is we can't do adjustments as we go along for deprivation, because we don't know the whole cohort. So the gold standard, if you like, will be still the annual report that comes out of the M, because that will take the data, we'll clean it very carefully and produce a lovely shining report with these sort of outputs on it. But we're hopeful that the quarterly and the monthly eventually reports will be helpful to you, but there are caveats around that, and they will be on the displays when they come out.
Any questions for Justin? We can't let him away too lightly, can we?
Just a little comment. There's a lovely tool available to all. It takes about 5 minutes to use on a gov.uk sort of platform, where you can put in a file, maybe a CSV file, or it might even allow Excel, of your postcodes, and it will tell you your lowest quintile. And you can then just see exactly, you can see what your target population is then.
But usually, I mean, the clinical teams are pretty hot on knowing who needs what when.
The nurses know which house they need to visit in twos. Quite.
So I think the message is, despite where people live, and that can be it can put you on the wrong route, can't it? There are needs for families that have to be addressed individually. That's the really important thing here. I mean, I'm really delighted to see that the A1C continues to go down. Of course, it's going to get more difficult because, as you know, we did the easy work early on, but it is more challenging now. And you're right, we're using closed loop on families, young people that we thought, I don't think we we should, but we're being brave and we're going out there and doing it. So we would expect the A1C cumulatively to go up, and that is what. But that doesn't mean we shouldn't use high glucose, does it? It means we should more of it and shift the balance. So great work, really good work for everybody. Is there anxiety in the room about our ability to collect data as frequently as expected? Hands up. Does anyone feel this is going to be too onerous or really break the back? Come on, what do you think? Is there anxiety out there? Put your hands up if you feel you're anxious about our ability to send data more frequently than annually. So not a huge.
Quarterly is okay.
Yes. Yes.
Yeah, well, let's see the quarterly outputs. We're not saying that our contract with HQIP is to look at the quarterly first and see whether we can achieve that, and then reflect on it and see whether there's scope to move to monthly. So we have to wait and see how it all works. It's going to take a bit of time to bed in these things. When we change the data set, the first year we know we're not going to get 100% submission to it, but it gets better over time. So
I know there's quite a lot of new electronic patient record systems out there as well.
Yeah.
We'll sort of find our way to how we integrate those. So I know certainly
I think
I know not quite
sorry. I just think the message really from myself is that try and get administrative support. You know, our nursing team shouldn't be using their time, or the medical team, or the dietetic team putting in our data. We must have the right person to do the right job at the right time, and it is imperative that we free our clinical teams up to offer care and support and education for our families, and we have administrative support to do the data collection. It is really essential, but with oversight from clinical teams as well, because the admin may not understand the data as well as we understand it. So that would be what I would say.
Hey, just a request from people watching remotely. Would you mind speaking into the lectern microphone, or I can give you your own one in the in-between? They've been struggling to hear the conversation. It's fine. And to say to Justin, we've had some questions coming in on the chat. I've been answering them, hopefully, on your behalf.
Oh, thank you.
Yeah.
Okay. Just one quick one, and then I'm definitely going to go over to Reinhard. Yeah.
reporting our HbA1c. So our patients with the highest who we classified to be reds, we're trying to see on a monthly basis if we possibly can. And so they're having more HbA1cs recorded in comparison with who we, class as our greens, and that data, we're worried about that data skewing our overall results.
I would love to provide some reassurance around that. Hi, Holly Robinson, NPDA manager.
We take the median per patient for the time period studied. So at the moment it's annually. So if you've got 10 HbA1cs from your patients with 80 millimoles per mole, that's fine. We're only going to take one through to analysis to avoid the skew that you're worried about. So very happy to provide that reassurance.
Every patient carries the same weight of HbA1c.
So it doesn't have to be how many we put in.
No, because we'll take the average of those for the year, and they'll be the same as somebody who's done one HbA1c in terms of weighting for your clinic.
Yeah. One very sneaky one.
Do you think in the future we're going to start moving towards time and range instead of measuring HbA1c with the audit? Especially as more people perhaps go on CGMS. We know we've all got patients with HbA1cs at 7.5, but actually if you look at the amount of time the glucose is in target range, it can actually be quite small if they're swinging from high to low all the time. And I think that's beginning to unfold a lot more now that we're seeing more patients on CGMS.
Okay, I'm going to repeat that question just so people can hear it at home or in the office. So there's a question about whether we're going to collect information on time and range in addition to HbA1c, because it's an important clinical marker. And the response that we've had to that previously is that because not every single child or young person is on a CGM, we cannot. There's going to be a lot of skew in those data. Also, we try and minimise the burden on teams in terms of the data that we collect. We want to collect the minimum data for the maximum impact. So I think as more and more children are coming on to CGM, it builds the case that we should take these data. But if it correlates very highly with HbA1c, then we don't want to waste your time giving us all of those data. On the other hand, developments with our data capture system later on means that if there's data that it would be useful for us to collect but not necessarily report, we could think about adding in voluntary data items that you could use for your own analysis at home if it's something that we can't build a national picture around. So not for now, but maybe in the future.
So it's a dynamic thing, isn't it? The time and range, which you can use very nicely clinically when you see somebody once every 3 months or once every week if you're seeing more often. It doesn't lend itself quite so well to audit that HbA1c does, because that HbA1c covers a long period of time, whereas you could change your time and range overnight if you decide to just do something about it. But we take your point, and it may well come in. So I know Reinhardt may talk about it. Certainly in some countries they do collect that information, but they're a bit ahead of us in terms of everyone's on a pump in Sweden, everyone's on CGM. We're not quite there yet.
Soon to be, though. Soon to be. Watch the space. Is that right? Thank you very much, Justin. Big clap for Justin.